This is going to be a different lecture. I'm Jack Snitzer, by the way. I'm endocrinologist. I've been here for 22 years. So I think I've seen half the people in the audience and a lot of other people. And I think I've seen everybody in Salisbury at least once. But this is going to be a different kind of program. We're not going to talk about anything bad, we're not going to talk about how diabetes is damaging, essentially. We're going to be talking about how diabetes can actually be improved and where it came from, how bad it was, how difficult it was to treat in the old days, and how much better it got now. And we take it for granted, and in 5-10 years, when it gets even easier to treat or more choices and more distinct treatments that are more specific to diabetes, we'll be really appreciative of where we're going to. So this is going to be about then and now. And if anybody needs to contact me, please do at my office. Suzanne, my nurse, will be happy to relay any messages if you have questions. And I also want to thank the American Diabetes Association because it's been 75 years of existence now. They're celebrating their 75th year anniversary. And they just happened to have an article in Diabetes Forecast this past month that had a lot of stuff I could use in my lecture. So I have some information here. I actually had my lecture first, and I saw they had some good timelines, so I added some stuff there. Diabetes mellitus, that's the official name, or mellitus. There's different ways of pronouncing it. But diabetes is from the Latin, this term is from the Latin, diabetes for urine, and mellitus or mellitus for honey sweet, or sweet. Insulin is from the Latin insula, which means island, since insulin is found in the islets of Langerhans in the pancreas. We've known that for quite some time medically. 3,000 years ago, symptoms consistent with diabetes were diagnosed by the ancient Egyptians. So they knew that something was up then because people were having many of the symptoms, such as excessive urination and thirst, and they noticed at some point in time that the urine was sweet. And you can use your imaginations to find out how they did that. Diabetes was coined by this Aratus in Cappadocia. You don't have to remember that, there's no quiz. Who was from 81 to 133 AD. So the term diabetes is very ancient. Mellitus or mellitus was coined in 1675 by Thomas Willis in Britain. This is a multicultural disease we have here. 1776, which is a famous year in the United States, Dobson from Britain confirmed excessive sugar in the urine. It seems so common sense to us now, but in 1776 they finally confirmed that excessive sugar in the urine and blood was a cause of the sweetness. In 1889, the pancreas involvement in diabetes was discovered by these gentlemen, this group from Austria. Insulin discovery, this changed the whole map. Insulin discovery took us from people dying in days to months to years with diabetes to people actually living. And this was in 1921 with Frederick Banting and Charles Best. Banting was the bigwig and Best was his student associate who was doing a lot of the work for him. Marjorie was the first dog to receive insulin. John McLeod was a professor whose lab they used. He was a bigwig at the time, and again, this was University of Toronto, so Canada, and John McLeod offered his lab to Banting and Best. McLeod wasn't very excited about this at the time. He thought this isn't going anywhere, so McLeod offered them the lab. Then he skedaddled to, I think, take a trip in Europe for a while. Then when he came back, he was amazed with what was being done. So we have all these people to thank for insulin discovery. Bertram Collip is another one, helped purify insulin. In the old days, insulin wasn't really purified, so you could only get a little bit of insulin from animals, and I'll go into that in a little more detail in a few minutes. They won the Nobel Prize in 1923, 2 years after the discovery, and that's pretty unusual, getting a Nobel Prize that quickly after making a major breakthrough. So even back then, they recognized something big was happening. Banting and McLeod were the ones that got the Nobel Prize. Matter of fact, Banting was a little bit upset that Best didn't get the Nobel Prize, and there was a little give and take between Banting and McLeod, but they ended up sharing the award between all of them, so McLeod was very generous about that. Banting is on the right, and Best is on the left, and their dog is Marjorie. The dog actually lived for about a month afterwards, and there was no way a dog could live that long with insulin-dependent diabetes at the time. So the dog did quite well. January 1922, Leonard Thompson, a 14-year-old boy, was the first human patient to receive insulin from the extract of a dog pancreas. So you think about that, it seems gross now, just grinding up a dog's pancreas, extracting insulin, and then giving it to someone. It's not very sanitary, and it's certainly not sterile, but it was very helpful for him. He virtually immediately regained his appetite and strength after receiving this, just like newly diagnosed individuals with type 1 diabetes. When they go on insulin, they have the same thing happen. They get stronger almost immediately. Prior to this, in 1921, Banting and Best gave themselves insulin to test it on themselves. Not good science now, but they were really in a pickle that they had to figure out what it was doing. And guess what they got when they gave themselves insulin? They got hypoglycemic. They got low blood sugars. And they realized that it was causing dizziness, which was relieved by eating some glucose. It was first discovered in an extract of pancreatic secretions, originally obtained from dogs' pancreases, and then cows' pancreases were used. Then John McLeod suggested the term insulin. In 1923, Lilly started marketing and making animal-derived insulin, so they could get it from cows. If you remember beef, pork, insulin type things, that was when this all came into being. Then, in 1959, type 1 and type 2 diabetes are identified. Seems pretty simple now. There's two types of diabetes that we know about. Actually, there's dozens of types of diabetes, but we'll simplify it and say the main types are type 1 and type 2. That was 1959 they were identified. There was something different about type 1 from type 2 diabetes. Type 1 was called insulin-dependent diabetes. Type 2 was called non-insulin-dependent diabetes. That was pretty good for back then. Now we call type 1, we call them type 1 and type 2 diabetes. Age doesn't matter. Age or insulin use is not a deciding factor in if you have type 1 or type 2 diabetes. It depends what causes it. Type 1 diabetes is caused by the immune system attacking and destroying the pancreas. Type 2 diabetes is caused by resistance to insulin. Insulin doesn't work well. So they didn't discover this till years later, why type 1 and type 2 were different. Type 1 is, again, autoimmune attack on the pancreas. Generally, the pancreas eventually makes no insulin. Type 2 diabetes is generally caused by resistance to insulin, as I just said. 80 to 90% of people with type 2 diabetes are overweight, maybe up to 95%. Insulin resistance is usually caused by genetics, very strongly in the genes. If a parent or grandparent had it, their kids will likely have it if they're overweight. Type 1 diabetes, any age can be involved. You can get type 1 diabetes, which is what used to be called insulin-dependent diabetes. You can get that at 90 years of age. It's just a matter of when the immune system triggers and starts attacking the pancreas and destroys the islet cells in the pancreas, the beta cells that make insulin. We think of this as a disease of young people, but that's because for decades they called anyone who got diabetes in their 30s, 40s, 50s was called type 2, and that was absolutely wrong. So we don't want to call it juvenile diabetes. A lot of people take exception to that. Type 2 diabetes, any age can get this, but we classically think of people getting this as adults. Again, we no longer call this adult onset diabetes. When I was going through training, the abbreviation for this was AODM, adult onset diabetes mellitus. And now we feel bad that we did that because it was wrong. Again, you can get this at any age. You see the epidemic on TV of kids getting this who are overweight and have a strong family history of diabetes. So you see this blooming all over the place, and this is the latest epidemic. Pediatricians never had to deal with diabetes because any of the kids with type 1 diabetes, that was a lot of pediatricians, that was too complex. So they sent it to an endocrinologist. But now pediatricians are dealing with a lot of diabetes because they're getting a lot of type 2 diabetes in teenagers or younger kids. The incidence of diabetes is increasing. Type 2 diabetes is increasing in developed countries markedly due to increased incidence of being overweight. When you have lots of resources, lots of food, and not so much exercise and activity, obesity or overweight is caused. So you have more calorie-rich food and less activity. What does that cause? Insulin resistance from being overweight and for getting more calories than you actually burn off. Type 1 diabetes is also increasing slowly, it seems, but we don't know why. We don't know why type 1 diabetes is increasing. It's autoimmune. Are we just recognizing it more, or is it actually increasing? Well, the powers that be think type 1 diabetes is increasing also. Prevalence of diabetes in 2012, 29 million Americans, 9.3% of the population have diabetes. 8.1 million are not yet diagnosed. So there's 8.1 million people out there who have diabetes, getting complications of diabetes, and they don't know they have diabetes yet. For many reasons they don't know. And I'm talking in this case about type 2 diabetes, what we used to call adult onset. 1.25 million Americans have type 1 diabetes. So it's the minority of people that have type 1 or autoimmune diabetes. Age 65 and over, 26. 1 out of about 4 individuals over the age of or 65 and older have diabetes of some sort, generally type 2. And that's 11.8 million individuals in the United States. And that's undiagnosed and diagnosed. Under age 20, 208,000 Americans have diabetes and prediabetes. Prediabetes was just described a few years ago. We used to call it hyperglycemia or high blood sugar. Sometimes we called it borderline diabetes, but I always like to say borderline diabetes is like borderline pregnant. You just can't get it because it's doing things, even in the pre-diabetic stages, it's doing things to your body. So prediabetes, where the sugar is mildly elevated, or the A1C, which I'll talk about later, is mildly elevated. Prediabetes, 86 million Americans 20 plus years of age and older. So this is terrible. We've got to get these people diagnosed and treated, or at least do something to turn this around so they won't develop diabetes, prediabetes into diabetes. It was just found out a few years ago, as a matter of fact, that even prediabetes, pre-type 2 diabetes it might be called, you even can get complications when your sugars aren't that high. So we want to treat prediabetes before a person actually has complications. About half of individuals, when they are first told they have type 2 diabetes, have complications of diabetes. So we're missing something. We have to treat earlier. Some people are more sensitive to complications, of course. 7% of Caucasians have diabetes, 9% of Asians have diabetes, 13% of Hispanics have diabetes, 13% of African Americans, a little bit more than that, actually have diabetes, and 16% of American Indians, Native Americans, have diabetes. It's a leading cause of adult blindness and kidney failure right now. Again, we acknowledge the American Diabetes Association on its 75th anniversary, and I was able to use an excellent article on the history of diabetes as part of this. We'll talk about then. Then, a person with type 1 diabetes was told they would not live as long or as healthy as others. Remember this? This was scary. You were told, frankly, the day you got type 1 diabetes, that you would have a not so long and not so happy end to your life. And now, a person with type diabetes is told, and rightfully so, they can live as long and as healthy as most other individuals with some care. Rapid-acting insulins. Let's talk about rapid-acting insulins. Rapid-acting insulin initially was only insulin available. That's what they isolated from animal pancreases. That's what they had. It was from dogs and cows, then beef, pork. Insulin was mass-produced. Once they got to the cows, the beef, pork insulin, and the pigs, they could make insulin in very large quantities. So now they had enough insulin for anybody that needed it. The problem with beef pork insulin was that it was a little longer acting and caused the immune system to reject it. So people who are on beef pork insulin, they actually sometimes had allergic reactions to it. And those allergic reactions could be anything from rashes to the insulin not working well. The body neutralized the insulin. It didn't have the same exact components as human insulin. In between this, in 1973, there was a more highly purified beef pork insulin which was made, which could reduce allergic reactions. This was a godsend, really helped a lot of individuals. Now, we have rapid-acting human insulin, which is our insulin. Regular insulin is another name for it. Maybe not the best name for it, but we call it our or regular. It's still available, still very good. I'll talk about some other insulins in a few minutes. This is the same insulin that humans make. Rapid-acting insulin analogs were developed many years ago, over 10 years ago. We have insulins called Humalog, Novolog, Apidra. These are rapid-acting insulins that are more rapid-acting than human R insulin. And it tends to, in some people, these new insulins tend to match food better. So there's a whole bunch of new breakthroughs with analog insulins, which means by analog, I mean they take human insulin and they switch a couple amino acids. So the insulins are absorbed from the skin a little bit differently, a little bit better. In 1949, decided on specific units for measuring insulin. You all, whoever's on insulin here, you know that you take units, 5 units or 10 units or 2 units or 20 units. And it took them a long time. Before, people were just taking just fill up your syringe and take some insulin. Now, and half full, 3/4. Now, then they came up with a standardized way of doing it called units, which is a relatively non-specific term. It's not like grams or something that really specifies how much something weighs. Long-acting insulins. Then we came up with long-acting insulins. Long-acting insulins are a real breakthrough. And one of the reasons that long-acting insulins are a breakthrough is, if you remember, there's 2 main things that affect your blood sugars. There's actually many more things, but there's 2 main things that affect your blood sugar. One is what we eat, carbohydrates. Carbohydrates raise our blood sugar. The other thing that raises our blood sugar is our liver is always making sugar. The liver makes sugar all day long. Diabetics their liver makes more sugar. And when people with diabetes are under stress, the liver makes even more sugar. So what we need is some long-acting insulin that lasts 12 hours or 18 hours or 24 hours. And this long-acting insulin tells basically the liver not to make too much sugar. So if you ever wonder why you're on 2 types of insulin, long-acting and rapid-acting, it's because one's to fight food and to fight high sugars, that's rapid-acting, and one insulin is to counteract the fact that the liver makes too much sugar. So one insulin often doesn't do the job in at least everyone. So initially then, we had NPH insulin, and it initially was from animals, then it became human insulin. Humulin N or human N or Novolin N is identical to what humans make. So the difference is how it's absorbed from the skin. So human N insulin is absorbed more slowly from the subcutaneous area under the skin than our insulin is. These insulins have a disadvantage that they peak and trough over 16 to 12 hours. So the good news is they last longer. The bad news is they last longer. And the problem is they peak. If you take a shot of N insulin or NPH insulin, about 8 or 10 hours later, they actually reach their maximum in your bloodstream and they're working their strongest. May not be the best time for an insulin to work its strongest, 8 hours after you inject it. So they work well for some people, but you really have to work with them. So what happened now, we have longer-acting insulins, which are called basal insulins, which really don't peak. You take them once a day or twice a day, and they stay in your system for 24 hours at about the same level in your bloodstream. So these are long-acting basal insulins, Lantus, Toujeo, Levemir, Tresiba. And they're absorbed more smoothly from the subcutaneous area under the skin. These insulins have less peaks and troughs, therefore more smoothly absorbed over 24 hours. In 1982, the first synthetic human insulin, going back now, the first synthetic human insulin was developed. It synthesized insulin in a laboratory. A lot of people consider this artificial or unnatural, but this is human R. This is exactly what our body makes. Even though it's made in a test tube, it's exactly what comes from our pancreas. Rather than relying on pancreases left over from the meat industry, and using pancreases left over from the meat industry guaranteed that we'd be short on supply. Then people had to boil the metal needles and the glass syringes. There's some people in here who remember that. That was not a very fun time, and they had to reuse the syringes. And if you didn't boil them or were in a rush and they weren't sterile, you could get severely ill with infections from reusing the same insulin syringes and needles. They were glass syringes and metal needles that had to be sterilized. Now, in 1955, which is not quite now, but close, first disposable plastic syringe, which you still use plastic syringes. In 1985, first insulin pens. A lot of people here are on insulin pens. Insulin pens are relatively easy to use and very convenient. Now, I just wanted to throw this out here, a question. What is one major thing that differentiates how the insulins function? I touched on this a few minutes ago. The answer is how they're absorbed from the skin. Most insulin is very similar. It's just when you give it as a shot under the skin in the subcutaneous tissue, it's absorbed differently. And how rapidly it's absorbed differentiates these insulins. The companies that make insulin are spending much money into the technology of how to get a better, more consistently absorbed insulin from the subcutaneous tissue. Then, and a lot of people here remember this too, this was kind of a scary thing, urine testing of glucose. There was something called Benedict solution, mixed with urine and heated. So you had to mix it with your urine, then you had to heat it for it to tell you what your sugar level in your urine was. So not many people did it, and it wasn't very accurate. Then the first glucose testing tab called a Clinitest, where you could check your blood for sugar, that came out. That wasn't very precise, though. I'm sorry, that was a urine. Clinitest was a urine strip. I take that back. So Clinitest was a urine, like a dipstick, to check how much sugar was in your urine. Then, in 1964, Dextro sticks. This is the first blood testing strip. This is where you actually got some blood from your finger or wherever you wanted to get blood from, and it could tell you what your blood sugar, not overly accurate, but it wasn't terrible either. 1970, blood glucose meters were available for doctor's office, so it was only 1970 that doctors could check your sugar in their office. And then in 1981, you know, it seems like it's much earlier than this, but 1981, glucose meters were actually available for patients to use. And the first one was the Ames glucometer. When I went into practice, they were still using the Ames glucometer. Now we're not using that same device. Now we have many glucose meters. The biggest frustration is that we have meters and people won't use them. We have one device that can give a person control and knowledge about their blood sugars at any time, and it's a hard sell for some people because it's a finger stick. And because it's sometimes not fun to know that your sugar's high, and too much information can sometimes get to people, make them feel a little uncomfortable. But we have these meters that can tell you with high degree of accuracy what your blood sugars are at any moment of the day. You eat something you don't know how it's going to affect your blood sugar, guess what? You can check your sugar 2 hours later, see what it did. You have the power to know what your sugar is at any moment of the day. In 1966, the first successful pancreas transplant at the University of Minnesota. Now, Minnesota is still one of the top pancreas transplants institutions in the country, but there's several other ones, obviously. University of Maryland, Hopkins, they all do excellent jobs at pancreas transplants. That's for type 1 diabetics only, pancreas transplants. Oral medications for type 2 diabetes. For the longest time, we had nothing but insulin to give diabetics, whether they were type 2 or type 1 diabetics. In 1955, something called a sulfonylurea drug came out. It's a class of drug that makes you produce more insulin. Tolbutamide, and there's one called carbutamide, but we're familiar with tolbutamide. That still existed when I was in practice, when I started practice, I should say, 22 years ago. Problem with these drugs, they help the pancreas produce more insulin, and they can cause severe low sugars. A lot of people think of these drugs as the safest drugs we have. But you have to they don't have a lot of side effects except low blood sugars. Unfortunately, more people have died from low blood sugar reactions from these drugs than probably from the combined side effects of all the other drugs that have been available to treat diabetes. These drugs are good. They're excellent drugs. They work well, have to be used cautiously in the right people. We still have them, but we have newer versions of these drugs. The second generation sulfonylureas became available, glyburide, glipizide, and glimepiride. Another oral medication for type 2 diabetes, which was a breakthrough, there was something called fenformin, which was taken off the market in 1978 due to something called lactic acidosis. And then a new drug that was related to fenformin but safer, in 1994, metformin became available. This is the most used diabetes pill and recommended for virtually all patients who can be on it who have type 2 diabetes. It's only for type 2 diabetes. So metformin is for type 2 diabetes. If you have kidney or liver problems, you cannot be on metformin. Other oral agents, now we have dozens, well, we don't have dozens, but we have about a dozen oral agents for diabetes, classes, I should say, they treat diabetes in different ways. They're complementary. We have glitinides, which make you produce more insulin. We have alpha-glucosidase inhibitors, which make you pass urine in your bowel, pass glucose in your bowel movements. You actually we have a bowel movement, and you get rid of sugar that way. You have TZDs, which is a thiazolidine dione. They make insulin work better, make you more sensitive to insulin for a type 2 diabetic. These are all for type 2 diabetics again. Then you have something called DPP-4 inhibitors, bile acid sequestrants, something called bromocriptine, and the newest ones, SGLT2 inhibitors, which make you urinate out sugar. We have the DPP-4 inhibitors I skipped over, but they make you also produce insulin. And now we have some relatively smarter pills that make you only produce insulin on demand when you need it, when you eat or when your sugar's high. Now we have newer ones. These are injectables, GLP-1 agonists, which are injectables that make you produce insulin only when you need it. And Similan, which is one that's not used too often, but it can be used for type 1 and type 2 diabetes. And some people remember this, we had an inhaled insulin called Exubera. It didn't go very far, and I'll show you why in a minute with a picture. It was a very cumbersome device to use. Now we have an inhaled insulin called Afrezza. As of June 2014, it was approved. 8 years after Exubera was taken off the market, a new inhaled insulin came into being. This was Exubera. It was an inhaled insulin. You see that device here. They had to put some insulin in a powdered form into this and then suck it through this device into their lungs. So it was hard to dose, and it was just a cumbersome device. This is Afrezza. This is the new inhaled insulin. It fits in the size of your palm. It's a very small device. If you look on the right, that green and the bluish color cartridge, that contains powdered insulin. And you put it into that white device on the left, and then you put it in your mouth, inhale it, and you get inhaled insulin. Then, remember this too, a diabetic diet consisted of food, consisted of food that was not what a person would ever be happy eating regularly. Now, the 2001 ADA, American Diabetes Association, focused the diet on moderation, not deprivation. So in the old days, if you had diabetes 20 years ago, 20 years ago, 30 years ago, et cetera, they would tell you that if you liked it, you can't eat it. And that, you can imagine how that diet worked. Not very well for a lot of people. So now, as of 13, 14 years ago, they've changed it to moderation. There's nothing a diabetic can't have. There's some things a diabetic shouldn't have, and some people with diabetes just can't have certain things, but because they've just realized it's not good for them. But a diabetic diet is a healthy, full meal plan that can include the full range of food in moderation. And we talk about insulin pumps then. Insulin pumps is a concept that really started to gel in the 70s. Although we had an insulin pump in the 60s, which I'll show you in a slide or two, they first tried intravenous insulin delivery. It sounds like a no-brainer, giving insulin intravenously, just like the pancreas does. You try to get insulin given into the bloodstream. Didn't work. Clotted, got infected, there were too many problems. So they gave up on that, and then they said, let's give insulin under the skin, just like with a pump, just like we give shots, but we give it continuously under the skin. So that's called CSII, or continuous subcutaneous insulin infusion. Human trials began in the late 1970s. Initially, pumps were very large, worn as backpacks. This was the first pump in 1963. Now, this was interesting because this gave not only insulin, but this gave another hormone called glucagon. So this gave two hormones to treat diabetes simultaneously. Didn't take off, although it looked like a jetpack, but it didn't take off. Yes. Then you have insulin pumps now are much smaller, Several companies make insulin pumps: Medtronic, MiniMed, Animas, One Touch Ping or Vibe, Tandem, T-Slim, Omnipod, Accu-Chek. Pumps try to mimic the natural secretion of insulin during the day and with food. In other words, the pump gives you a little bit of insulin all day long. Then when you eat, the wearer of the pump has to push the button to give more insulin based on what they're eating and how high their sugar is. Pumps use rapid-acting insulin only. And this is I'll just go through this fairly quickly. This is a Medtronic MiniMed pump. This is an Animas One Touch Ping pump. And in the bottom, you can see the infusion set. This is a tube. The insulin is in the pump on the top, goes through the tubing, and comes out that little cannula in that. It's called an infusion set on the bottom. And that's what's, there's a little plastic cannula that's inserted under the skin with a needle that stays there for about 3 days. You change that every 3 days. This is called the T-Slim pump. This is the Omnipod pump. This is the Accu-Chek Spirit pump. And then we have something called continuous glucose sensors. They monitor the blood sugar every 5 minutes with real-time readings. So in other words, you put this on, it's a sensor you leave on, you tape it on, it's a little wire under the skin. You leave it on about 6 or 7 days, and every 5 minutes it gives you a reading. This is called the Dexcom. There's a G4, now the new one's a G5. This one now can actually read to your iPhone. If you have an iPhone, every 5 minutes it can tell you what your blood sugar, because it can be wirelessly linked to this. This is also the Dexcom, just going over a bunch of the Dexcoms. MiniMed with CGM stands for basically continuous glucose monitoring, or the sensor. MiniMed has their own sensor device that has something called threshold suspend, where if it detects that your blood sugar is too low and you don't respond to it, it will beep and say your blood sugar is low, do something, and if you don't, it will turn the pump off, assuming that you might be passed out from a low blood sugar. Then the patient didn't take part in their diabetes management other than their medications, taking their medications regularly, hopefully. Now, things are totally different. Because we have so many more medications, we have to get the patient more involved. We have the people go to diabetes education classes. We have the patient learn as much as they can about diabetes. Go to nutrition management classes, which is called MNT, or medical nutrition therapy, and learn healthy dietary choices. We want the patient with diabetes to have a healthy, comfortable life and not live their life necessarily confined by the diabetes. We want the diabetes to live inside, to work inside a healthy lifestyle. And learn healthy dietary choices, and if possible, how to count carbs and match their insulin to the blood sugar level and to their carb intake. Now, not everybody can do this, not everybody needs to do this, but if a person can actually learn how to match their rapid-acting insulin to their food and to what their blood sugar level, think about it. If you eat more, you take a little bit more insulin. If you eat less, you take less. If your sugar's high, you take a little bit more insulin. Lower, you take a little bit less. We have people that can teach you how to do this. And again, not everybody needs to, and not everybody can do this, but it's something to think about. Then, doctors really didn't involve the patient in the diabetes management decisions. We told the patient what to do, how much insulin to take, and that was a big problem, because if they were on pills or insulin and they ate totally different, they would be having problems, low sugars, high sugars, and they didn't know what to do. What's more frustrating than that? Not being able to have any control over what's going on. Your sugar's high, you're on insulin, you don't know how to fix it. Well, there's ways of learning how to fix it if you're so inclined. Now we have patients check their blood sugars at home and try to organize the data to give us better information with which to help them and their medical team to make decisions. In other words, when somebody comes to my office, I often hope that they have a record, either their meter or a logbook, or they have some thoughts on how I can help them. Where's your sugar high? Is it high in the morning? Is it high at bedtime? Is it high at dinner time? Is it high at lunchtime? No blood sugar stands alone. If you're high in the morning, well, I shouldn't say high in the morning. If your sugar is high in the morning, you got to be careful in this climate now. If your sugar is elevated in the morning, then I want to know why it's high in the morning. Did you go to bed with a 400 blood sugar, and that's why your sugars are high in the morning? Or did you go to bed with a sugar of 120 and your sugars are high in the morning because your liver cranked out a ton of sugar while you were sleeping? I can guess at how to treat somebody if I don't know the answer to that. But by knowing the answer to that, I can make an educated decision on what needs to be adjusted. So if you can give me information on that, it will save me from telling you to go home and then collect that data and then call me up in a week or two, or making a guess. Then we didn't encourage exercise enough, cautious exercise, because remember, a lot of people with diabetes don't have symptoms of heart disease. The first symptom of heart disease, and oftentimes in a person with long-standing diabetes, is shortness of breath, with exertion especially. So I don't want a diabetic patient who's never had exercise before go out and run a marathon the first week. You have to do it cautiously, slowly. If you get short of breath, take it slow, and see a cardiologist, get a stress test. Now we hope that cautious exercise is a part of most people's treatment regimen. Then patients took rapid-acting insulin at a constant dose and didn't change the dose if they were eating more than usual or if the blood sugar was higher than usual. I've already talked about this. Now we try to teach the patient to count carbs and match their insulin to what their carbohydrate intake is and what their blood sugar level is. It can be really helpful if a person can do it. Then there were no particular goals of therapy, and this is really important too. We used to tell people, just take your insulin, you'll be fine. Take your medicine, you'll be fine. Well, you know what? They weren't fine. So we were probably doing, 30, 40 years ago, we were probably doing very little good. In between, we encouraged very tight control. Even like 5 or 8 years ago, we told people, you have to have the tightest control ever. You have to have your sugars down to below 100 a good portion of the time. And then we found out that that was contributing in ways we don't understand to more death, more cardiovascular death. But not in everyone. And now the goals are targeted to each individual. Who are you as an individual who has diabetes? That will tell me what goals. Should your A1C goal be 7%, 8%, 7.5%? Should you try to get your blood sugars between 70 and 120 most of the day, or between 120 and 200? Depends on who you are and what you need. Target goals are certainly individualized now. We also obtain an A1C to indicate what the blood sugar has been averaging for the past 3 months. Remember, the A1C blood test, which I have another slide on, tells us what the sugars are averaging for 3 months. What doesn't it tell us? Why the sugar is averaging that. If your A1C is 10%, meaning you're averaging about 244 blood sugar for the past 3 months, is it because you're going high after you eat? Is it because you're going high in the morning? Is it all of those? We don't know. That's where the meter comes in. Tell us where your sugars are going high, and we can pick a medication that will work best. In 1969, the A1C was identified as a marker in diabetes and proposed for use in monitoring people with diabetes in 1976. Again, the A1C measures how much sugar sticks to hemoglobin. And hemoglobin lasts about 3 months in your bloodstream, give or take. I'm simplifying it. And so eventually they figured out if so much sugar sticks to your hemoglobin, that means your sugars are averaging this or that for the past 3 months. Now the blood sugar goal in A1C is individualized for each person. I've mentioned this a couple times because it's so important that there's no standard. Not everybody has to get to the same target range. But complications do decrease about 3% for every 1% decrease in A1C. But why do we tell people they shouldn't all have an A1C of, say, 6%? Because we don't have medicines great enough to get them there without lots of low blood sugars. And low blood sugars have always been the limiting step in treating diabetes. There was a study called the DCCT in 1993. I was just finishing training when this came out. It was for type 1 diabetes, and there was another trial called the UKPDS, United Kingdom Prospective Diabetes Study, in 1999 for type 2 diabetics. This showed, the DCCT showed for the first time that better blood sugar control actually helped prevent eye damage, kidney damage, nerve damage in people with type 1 diabetes, and the UKPDS did the same with type 2 diabetes. Before that, we thought that better sugars helped, but we had no proof of it. And that's not that long ago. 22 years ago, we really had no clue for sure that treating diabetes made a difference. In 2001, there was something called the GlucoWatch Biographer, which was a watch that zapped you with a little ultrasound. You wore it as a watch. It zapped your wrist with ultrasound and made you sweat a little bit, basically. And it measured the sugar it wasn't really sweat, but in the sweat-like fluid. and it didn't pierce the skin. It was removed from the market in 2007. It wasn't accurate. People didn't like it. But this was a GlucoWatch biographer here. In 2001 and 2002, 2 studies came out that indicating that type 2 diabetes can be prevented or delayed with eating healthy and with activity. That makes a lot of sense. If you have pre-diabetes, your sugars aren't quite high enough to have diabetes, and you exercise, you can lower the risk of your diabetes turning into pre-diabetes turning into diabetes. And if you eat healthy, you can do the same thing. If you lose weight, if you're overweight, you can actually prevent it from ever happening. You can prevent pre-diabetes from turning into type 2 diabetes at all. In 1990, this is something that's a sort of a pet peeve of a lot of my patients and myself. 1990, the Americans with Disabilities Act came out promoting equal opportunities for people with disabilities, handicaps, including people with diabetes. Now, as you all know, some people who are looking for jobs with diabetes who work driving a vehicle, there's still some prejudicial laws out there. But they're getting better at, we're getting exemptions now. In 2003, a federal ban preventing people on insulin from driving a commercial vehicle is lifted, although you must get exemption. And to this day still, if you drive passengers commercially, you're not allowed to be on insulin. So if you get the logic of that, what that's telling people is, I'd rather have your sugar 400 and you can't see straight, and drive a bus with children on it than be on insulin and have better sugars. But the scare is low blood sugars. So we need to keep improving our treatment. The future, artificial pancreases, an insulin pump that does it all. Improved continuous glucose sensing and integration in delivery systems. In other words, an insulin pump that contains a glucose monitoring system, kind of like we have now, but maybe a little bit better. Stem cells that become pancreases. That's going to be coming. Discovering what causes insulin resistance in type 2 diabetes. If any of you want to go into this research and discover what causes insulin resistance, you'll retire in a couple days, because this is a very, very important big field. Genetics research, individualized treatment plans. We need to get each individual patient and say, this is a medicine that would work best for you because of this. And that's coming too. Better diabetes education programs for all involving the patient with diabetes, better than we do now. Trying to get the patient to participate. It's hard because diabetes is not an easy disease. Whoever has it knows it. You wake up with it, you go to bed with it, you might do good today, doesn't mean you'll do good tomorrow. It's a frustrating thing, and it always is there. I always try to tell my patients when they come to the office that you're not being graded in your diabetes. I'm not going to give you an A today because you had good sugar, or B or C tomorrow. I'm not the diabetes police. We all got to sort of take care of ourselves and work on this as a unit. The summary, we have come a long way, helped by dedicated patients, dedicated physicians, dedicated scientists, researchers, technology companies, and educators. We have a long way to go. Diabetes can be a very labor-intensive, data-driven, user-dependent condition, and to treat well, this means we all need to work together. And I think what I'll do is say thank you for your attendance. I know it's hot in here. Be healthful, and if you have any questions, I'll be happy to take them. Okay, thank you. Any questions out there? Yes?
Doc, how does an A1C test work? What does that number mean?
The question was, how does an A1C test work? A1C, actually the real name for it is hemoglobin A1C. So it's derived from how much sugar sticks to the hemoglobin. And hemoglobin lasts 3 months in our bloodstream. So what they did was over time, they figured out how much hemoglobin sticks to the bloodstream, and then using basically continuous glucose monitoring or checking blood sugars frequently, they said, oh, if X amount of sugar sticks to your hemoglobin, that means your sugars are averaging this over a period of 3 months. So it just measures how much sugar sticks to the hemoglobin, which lasts in your system for 3 months.
So is that a one-time test?
We can get it, most people with type 2 diabetes get it about every 3 to 6 months. And people with type 2 diabetes get it every 3 to 6 months. And people with type 1 diabetes will get it maybe every 3 months. You shouldn't get it really any sooner than every 3 months because it's a 3-month average. It takes a while to change.
So if I'm 400 today and 30 tomorrow, do I have an average?
That will be a nice average, but you might not do as well as you think. Yeah.
What does the A1C, is it showing an average?
Right. It will show you an average of every second of the day for the past 3 months. Right. Yeah. And that's why there's a lot of debate. Like if somebody has an A1C of, say, 7%, which means your sugars are averaging 154 for the past 3 months. If you have one person whose blood sugars are always 154, and you have another person whose sugars are 40 sometimes and 300 other times, but it happens to average 154, who does better? And we don't have an answer to that. There are a lot of data suggesting that the person who has more stable sugar does better. But there are other studies that said, nope, if the A1C is the same, they both do the same. I tend to favor that the person who's more stable does better. I think there are more data to support that. So you had a question back there?
A person's hemoglobin, if it's low, stays low. So how would this really affect the diabetes as far as the numbers are concerned?
That blood test, if your hemoglobin, like you're anemic?
Yes.
The question is, if you're anemic with a low hemoglobin, how does it affect that blood test? And the answer is a lot. So if a person's severely anemic, or if they have what we call hemoglobinopathies, like sickle cell anemia or other hemoglobin diseases, the hemoglobin A1C is a useless test in a lot of them. So you often can't trust it. Or if you got a blood transfusion, if you get a blood transfusion, you get an A1C after that, you're partially measuring the hemoglobin A1C in somebody else's blood. So, doctors know this for the most part. So they'll take it with a little grain of salt if you're very anemic, or if you have different types of hemoglobin discrepancies. Yeah, I saw. Yes, back there.
How about MPO status? Does that affect the result of the A1C?
The question was if you're fasting for the blood test. Is that correct? Yeah, fasting doesn't affect the A1C blood test. You can go into your doctor. As a matter of fact, it was probably about 15 years ago where I finally, I think, by my telling my patients that they could go to the labs non-fasting, the labs finally incorporated that you don't have to be fasting. So an A1C does not have to be fasting. Because it's a 3-month average, what you last ate doesn't matter.
But if your hemoglobin is concentrated because you're low, that still doesn't affect it.
No, the concentration, like if you're dehydrated, that doesn't affect the hemoglobin A1C. No. Okay, well, thank you very much. I'll be up here if you have more questions that you want to ask privately. Thank you.